Hello, everyone. Thanks for joining this first public event in the IARC Summer School. And I hope that you will enjoy this first event of a long series of 12 events throughout the month of June. So today is the first one with social inequalities in cancer. This is part of the prevention module. And we have our 35 participants attending in the Zoom, and we have over 550 people registered and watching us on YouTube. So just a few logistic information. We will have a session with questions after the presentations. The session will finish at 2. So before we finish, we'll have this question and answer session. Please, participants in the Zoom, write your question in the chat, and I will ask the viewers on YouTube to do the same. We will try our best to answer and address all of them. And now, without any further ado, I will leave the floor to our chair today, Dr. Salvatore Vaccarella, who is a scientist in the cancer surveillance branch, and will also be our chair today. He's also the scientist in the cancer inequality team at the International Agency for Research on Cancer. So please, the floor is yours, Salvo. Thank you.
Thank you very much, Sandrine, and good morning or good afternoon to everyone. Just the time to share the slides. Let me see. Okay, I think, can you see the slides? Sandrine is all okay with the slides? Okay, so today I will, I'm very glad to speak about on the IARC summer school about the social inequalities in cancer and what is the potential for prevention. This is a topic that is receiving more and more attention and visibility, and for some reason it has been a little bit overlooked over the past. So I will give a brief introduction, and then I will give the floor to Isabel Mosquera for her talk. So what are social inequalities in cancer? Social inequalities in cancer refer to differences in cancer mortality or incidence across social groups. So this means that usually what we see is that social groups that are usually located in the lower hierarchy of the society, either the poorest or the less, those with a lower socioeconomic position or status, have higher rates of cancer, either of getting cancer or dying from cancer. So this slide exemplify a little bit what I mean. And what another interesting thing is that there is a gradient across the whole population, which means that everybody is involved, and so means also that the risk increases as socioeconomic position decreases. And so why we see these differences? These differences we see because people with low socioeconomic condition usually are exposed to a larger number of risk factors. For instance, risk factors for cancer, for instance, smoking, drinking, or certain types of infection, or they're more likely to be obese. And also because they have limited access to the healthcare system, so limited access to early detection methods or to effective treatments. So these are this what we observe is relatively easy to understand. However, this has not been acknowledged as much in current epidemiological research, but also in policies. So, so why these differences exist? Because all the so-called social structural determinant of health, and the structural determinant of health and of cancer are all these conditions, social, economical, political, cultural, legislative, environmental factors, basically the context where we live, the way the society is organized is determining exposure to risk factor or risk factors for cancer, or is determining whether some individuals have higher or lower access to the healthcare systems. This is an important concept to keep in mind. And let me see the next slide. You can think about our society like a football pitch that is not flat, but this football pitch is unleveled. So for certain people, it's easier to score a goal, and for other people, it's more difficult to score a goal, where scoring a goal is being in a good health, let's say. And so it depends only relatively, it depends on the individual only in relative terms, because if this field is very unleveled, it is very difficult for certain social group to maintain a good health. And usually the society has structured so that there are more advantages for the affluent people and less favorable to those that have a lower hierarchy in the society. So as mentioned before, the global agenda is now being more aware about this, and there are several, since the 2000, there have been several events or documents endorsing the fact that inequalities need to be accounted and accounted for and dealt with. So there has been many documents from the WHO, WHA endorsements, and the mention on the Sustainable Development Goals, and also at the European level, there has been the European EU Beating Cancer Plan with the establishment of the cancer inequality registries. And as IARC also, we tried to emphasize this topic, and there was a few years ago the production of this scientific publication specifically focused on socioeconomic inequalities in cancer, and that provided also a recommendation on how to reduce them. By the way, if you want to have a look, this is a free publication. The PDF is free, and you can have a look at it. And this is another publication that we recently done. It's a study that we recently done and is focused in Europe, and it has to do with the comparison of socioeconomic inequalities in cancer mortality across European countries. I will show you in the next slide why it is important that these data are comparable across countries, because it shows that whereas in some countries inequalities are socioeconomic inequalities are relatively small, whereas in other countries they are very high. I'll show you an example very soon. But before, I want to say that this type of data are not very common, are quite rare, and especially outside of Europe, it's very difficult to find such a data, but it would be important to have more and more of this kind of data, even outside Europe. So, in this study, it was found that socioeconomic inequalities in cancer mortalities are affecting all countries and practically all cancer types. And this, you can see an example here. This is the rate ratio of low versus high educated groups. This is for all Europe combined. You can see the certain cancer, especially those related to smoking, that stick out a lot with the largest discrepancies between low and high educated. In men, we see especially smoking-related cancer, lung cancer, pharynx and larynx. The same in women, but also with the additional of cervical cancer, which is one of the cancer with the highest socioeconomic gradient. And when we compare countries, and this is where I wanted to focus a little bit on why it's important to to compare countries, to have studies that compare countries, that we can see here that these are the acronym of the different countries in Europe. The black dot represents low education, the small gray dot represents intermediate education, and high, the empty dot represents individuals, women with high education. You can see that in every country, the black dot is on top, is higher than the white dot. This means that there are socioeconomic inequalities in every country, but as you can see, there is a large heterogeneity. So in some countries, these inequalities are very large, especially if you focus on the right side of the panel. And interestingly, another thing that we found is that for high educated women, the risk of dying from cervical cancer is relatively low, no matter where they live in Europe. You can see all the mortality rates are included within this relatively small range. But for the most disadvantaged, those less educated women in some countries, especially those on the right side of the panel, which correspond to a geographical area of Eastern Europe or Baltic countries, for low educated women, the risk of dying from cervical cancer is very high. And we've seen this kind of pattern for many other frequent cancers, including smoking-related cancer. So this is an interesting pattern to keep in mind. And another thing that you need to keep in mind is that all the differences that we see, the average differences that we see between countries, when we see in these countries cervical cancer is more common than in other countries, these figures, this data show that most of these differences, average differences, are down to socioeconomic differences within countries. So another finding is that lung cancer is increasing among women in many European countries. And is increasing particularly for low educated and low socioeconomic groups, even in countries where a long-established tradition of equitable and social justice has been there for a long time, such as the Nordic countries. And you've seen that, okay, so overall, you see that women are affected a lot by socioeconomic inequalities in cancer. And I will show you another example later why this is important. But to conclude, in Europe, we found that 1 out of 3 cancer deaths in men are associated with educational inequalities, and 1 in 6 among women. But this proportion grows considerably when we restrict to Baltic or Eastern European countries in Europe. It's practically 50% of the cancer in men, and 1 out of 4 cancer in women are associated with the socioeconomic inequality. So this is an important factor to always to consider in our studies or when interpreting some statistics. Unfortunately, outside Europe, we don't have such data yet, and it would be nice to have them, but we do not have them yet. But what we know outside Europe is that, and this in particular for what concerns women, that if and especially if we consider younger generation, we see that 2/3 of the cancer diagnosed among 20 to 50, to individuals that are 20 to 50, so relatively young adults, occur, 2/3 of this cancer occur among women. This is quite a striking result. And the 3 most important cancer that contribute to this result are breast cancer, thyroid cancer, and cervical cancer. There are different reasons and different geographical distribution. This we're talking about worldwide, but they tell us that women are likely to suffer, especially the young generation of women are going to be probably more affected about cancer as compared to men. And why this is important, another study done in IARC here by Florence Guida and Valerie McCormack shows the societal consequences of this. In particular, they estimated that the number of maternal orphans due to cancer, this number was as high as 1 million children that they lost their mother due to cancer in 2020. Whereas the prevalent number of maternal orphan due to cancer in the same year in 2020 was 7 million children. So you can imagine that these children, for these children, most of them will live in low socioeconomic condition, and so this will somehow perpetuate a cycle of disadvantage and poverty. And this study is very interesting because it shows the mechanism on how socioeconomic inequalities in health and in cancer are reiterated and perpetuated over the generations. So in summary, reducing social inequalities in cancer, what are the priorities? First of all, we understand more and more that socioeconomic factors are the single most important factor explaining explaining the pattern, the global, national, and subnational patterns of cancer for every cancer type and in every country. So it is important to generate more knowledge, what I was telling before, create more data that are capable to measure these inequalities. There is a lot of room to focus on prevention because what we see usually, the differences we see within the same population usually are not inherited, but they are preventable. So this kind of inequality also gives you the potential for prevention. And also a recommendation that came out from the IARC scientific publication is that cancer control programs and in general research should be designed to at least not to exacerbate social inequalities in cancer and not to focus only on national average indicators, but ensuring benefits to all the segments of the society. Also, it's important to acknowledge the fact that this should not be left only to the individuals, but should be also undertaken at the higher level. And if you want to have a look a little bit more about this topic, you can surf on this on our website, where we study several issues about the topic of socioeconomic inequalities in cancer. And now, after this introduction, I would like to introduce to you to Isabel Mosquera, who will carry out the next talk, Barrier to Cancer Screening. She's a pharmacist. She's got a PhD in public health, and now she's a scientist in the Early Detection, Prevention and Infection branch, EPR in IARC. She has conducted research on health inequalities and focusing predominantly on cancer screening, and in particular on colorectal cancer screening. Currently, she's working on the assessment of barrier to the cancer screening pathway in Latin America and Caribbean. And Isabel, I will leave it up to you, and then later we will be happy to get some questions from you. Thank you very much. I'll stop sharing now.
Thank you, Salvo. Okay, now I'm sharing my screen.
Yes, you just need to put it in a
presenter. No, thank you. So thank you, Salvo, for this introduction, because this makes easier, like at the beginning of my presentation. As Salvo has been explaining, we know there's an unequal distribution in society of cancer. And we see one of the reasons, and already Salvo pointed it out, was that there could be, to explain the inequalities in mortality, that there could be a lack of access to quality assured screening. So here I'm showing you some data from several selected countries in Latin America and the Caribbean, where they looked at the screening coverage by income level. And you can see here in a very consistent way that women with the highest income level have a higher coverage than those with the lowest income level. You see this for cytology and for mammography. And we also have data, a bit old data, I must admit, from 2009, on this, looking at these inequalities also by income across OECD countries for breast and cervical cancer screening. And you can see, for example, if we look at the case of in Belgium for breast cancer screening, there's a big difference between the high-income women and the low-income women regarding coverage. We also see that some countries with hardly any differences between the different income levels, for example, Denmark for breast cancer screening and Mexico for cervical cancer screening. But we also see them at the lower part, let's say, of the coverage. So we would aim is to have hardly any inequalities, if not any, but with a high coverage, as the case of Spain for breast cancer screening. And these inequalities can be seen also, for example, by education. So we see, for example, in the case of Czech Republic and France, you can see the educational level in the Czech Republic, having a high educational level, you can see the coverage is around 60%, but with a lowest educational level is over 20%. Then you see also the case of France, where there's hardly any difference between the different educational levels. So here I've been comparing different inequalities by countries, but also we have within the same country, we can see by a geographic area. This is an example from Mexico, from data from the Ministry of Health, for the population covered by the Ministry of Health, that isn't all the population in the country. And you can see that out of 32 regions, less than half have a satisfactory or excellent screening coverage for either breast cancer or cervical cancer. So this is some like the background that made us work at IARC in a project looking at inequalities in the cancer screening pathway in Latin America and the Caribbean. And we looked at barriers at 6 different levels, adapting a questionnaire that had been used previously in Europe to looking at equity in cancer screening. So in the questionnaire, what we did was, as I said, adapted it, speaking with experts from Latin America and the Caribbean. And the steps we looked at were the development and update of protocols and guidelines and the capacity building around them, the identification and invitation of eligible population, then the participation to screening, the operation of the program, the follow-up and treatment. And we presented to the countries questionnaires on the questionnaire on questions on each of these 6 steps, giving them several options of barriers for them to prioritize which were the most relevant barriers in the country. And then we, based on this framework, we developed like our own framework. So in this framework, you can see the different dimensions of coverage that we have to think of if we want to achieve effective service delivery. So you see at the bottom, let's say here that we have to have, first of all, the services available to the population. This means available thinking of infrastructure, equipment, consumables, health personnel trained on screening in our case. Then if services are available, we have to see if they're accessible for them. So Tanahashi included here, for example, distance, costs. We can have also language barriers. Once the services are available and accessible for the population, we have to see if they are acceptable for the population, if they will be willing to use this service. And after that, we have to see if they're willing to use them and they actually contact the services. Well, what's the situation then? What happens? And then once the population have used the service, if it's effective or not, the care they have received. So based on this framework, we developed ours, and you see quite many similarities, but also some differences. We've kept the dimension of availability. We divided access in 2 different dimensions, accessibility and affordability, because they have different interventions that we will need to use to approach them. We kept acceptability and contact, but then we divided the effectiveness of services in several subdimensions because this is like a huge dimension with many barriers that we needed to subdivide. Because I didn't say, but this questionnaire was addressed to that, like to capture information on the health system perspective. Obviously, the priorities for the patients, for example, would be different. So looking at this framework, first of all, we have the availability of services. And as I was saying here, we include the infrastructure, human resources, the financial resources, equipment, consumables. And in this study, what we saw in the Latin American and Caribbean countries, the prioritize, one of the most relevant barriers for them is the insufficient infrastructure and financial resources for screening. You see 16 out of 22 countries mention this barrier as a priority. So that means nearly 73% of them saw this a relevant issue. There was also other countries that were focusing on FED assessment, and they mentioned they didn't have enough human resources to actually to conduct this FED assessment. You see 27%. Looking into access, we have, as we mentioned, we had accessibility and affordability. So thinking of accessibility, we had issues mentioned regarding distance to the screening center or the treatment center. There was also difficulties having getting an appointment. Maybe that difficult take time to get the appointment, that time is not adequate, or many other issues. And one of the most reported barriers was the delays for actually initiating treatment for cancer. You see, it was in 63, nearly 64% of the countries mentioned this as a priority when we were asking them about barriers at the treatment level. And then looking at affordability, we have to think of both direct costs for screening, for actually conducting the procedure, doing the analysis of the test, and indirect costs for those, for example, the cost that to go to the transportation to go to the screening center may not be affordable for the person. It could be also that the person has to stop working one day and they can't afford doing that to go to screening or for treatment, for example. Or for example, if you have to take care of a dependent and you can't leave that person and you have to pay someone, that's not affordable for the population. Looking into acceptability, here we have barriers regarding the low health literacy of the population, or having beliefs that make them not participate in screening or in the next steps. And also we have the distrust in the healthcare system. You see, they want like the most relevant barriers, but still like 36% of the countries mention the beliefs and health literacy an issue, and 13 the distrust in the healthcare system for participating in screening. Once we look at the contact, actually contacting the services, we saw an issue in several countries mentioning that the health professionals weren't actually promoting doing screening or the next steps. And also, you see in 40% of the countries, there was a limited promotion of the public promotion of the screening program. And now going into this part of the effectiveness of services, first of all, we have the governance, this part related to the coordination of the screening program and the setting all the legal framework around it. And we see that in more than half of the countries, they reported as a priority that they didn't have a well-defined system that ensured that the screen positive cases were appropriately managed. In slightly less than half of the countries, there wasn't an adequate planning for screening. Then, as I was mentioning, there was issues regarding the processes and legal frameworks. And also another issue could be the data protection regulations that prevent the screening program coordinating team to have access to the contact information to actually be able to contact this eligible population for screening. Also within this effectiveness of services big dimension, we find the protocols and guidelines that can be developed because of the legal framework that's set in the governance part. And we can see that guidelines may not be regularly developed or adopted. They may not be included in federal management, or we may have an issue of professionals not being trained on screening. You see, nearly 60% of the countries mention this as a priority. And then we have to be able to, obviously, to track the population along the cancer screening pathway. And so the information system is one of these dimensions that we have to look into. And we see that one of the biggest barriers at this point is the not having a contact information of the eligible population. This case is a bit different than the previous barrier I was mentioning in the data protection regulations, because here the issue is the data protection regulations do allow us to have the contact information, but we don't have the contact information of that eligible population. Then the population register may not be accurate or complete. There may be some population missing in this register. And also you see nearly 60% of the countries reported not having an adequate system for monitoring screening participation. And then obviously if we are tracking the population along all the screening pathway, we need to monitor this and evaluate what's happening. We have to ensure quality along all the screening pathway. And we could see here some of the barriers that they were not, screening providers were not following the protocols and procedures. or there wasn't a monitoring of the quality of the screening experiences. But then the most relevant barriers were the two at the bottom. So there wasn't a sufficient monitoring evaluation of people that were not that were screen positive but didn't go to follow up. And there wasn't a systematic monitoring of the treatment outcomes of patients that were actually having treatment for cancer. And so these are all barriers, but there's also some interventions in place that can be recommended. And I'm going to show you a framework we based on one from Baron. And this framework looks mainly at interventions to increase participation to screening. But we can think that they could be, some of them could be used also in the next steps in the follow-up or further management. So in this framework, we have like 4 different levels of interventions. We have, first of all, interventions that are directed to users. And what the aim is to increase awareness on the relevance of screening, and by doing this, to increase demand. And we find mainly educational interventions. So we have here the mass media, for example, television, radio, small media, for example, leaflets, one-on-one education and group education. But we also have individual invitation to screening, the reminders, and also incentives to individuals. Then at the next level, we have interventions also addressing users, but aim in this case to increase access. So here are mainly interventions that are looking at that as accessibility and affordability part that I was showing you before in one of the barriers. So we have, for example, regarding affordability, the intervention of reducing out-of-pocket costs. And then if we think of, for example, the barrier of distance, we can think of having mobile units accessing the area, different areas, providing transportation to go to the screening center, providing alternative screening centers, or, for example, self-sampling that can be used for cervical cancer screening or colorectal cancer screening. We have also the possibility of scheduling out of hours, out of the normal working hours of the health centers, offering the possibility of having this screening of the services. Patient navigation is another intervention that is being used to reduce delays along all the screening pathway, and can specifically focus on providing help to individual patients to overcome barriers that can be at a health system level, individual level, social level, or educational level. And then we have, for example, point of care services. In this case, what we are thinking of combining 2 services at the same time. So, for example, if someone comes to have cervical cancer screening, offer them breast cancer screening. At the next level, we have the provider-directed intervention. So here we find educating health providers, having reminders for them. For example, when a patient comes to the consultation with the GP, let's say, they can have a pop-up reminder that says that this person is due for screening, so they can like guide them in this sense. Then we have the provider assessment and feedback. So they actually are evaluated against other colleagues in the center or in the country, depends, and saying how they are performing regarding a set of specific indicators, and then provide incentives. And then at a macro level, we have these policies and systems level. We can have policies, for example, that facilitate participation to screening. And we can think, for example, of countries that have that give women a day off to attend cytology or mammography, for example. There can be other policies that actually address social inequalities in cancer screening. Obviously, one that covers this, like one of the most relevant, would be the universal health coverage. And we have to include also the having information system, the existing information system, and also linkage between databases to be able actually to follow women and ensure they continue all that pathway. So looking at, for example, some examples from Latin America, I brought here what would be the priorities they selected, three countries in the region. You see the prioritized barriers from this questionnaire I was showing you before, with these 6 questions on various the different steps. And you can see example of a Caribbean country, a Central American country, and a South American country. You can see, for example, that for the Caribbean country, availability wasn't one of the issues. You see it appears for the Central American, South American country. This doesn't mean that they don't have any issue, but it isn't a priority for them. You see, for example, acceptability was an issue for this Caribbean country, but not a priority for the other 2 regions. But you see in all of them, a big part of this framework is related to the effectiveness of services. So you see governance, information system, and quality assurance like quite present here. So this gives us an idea of like the dimension of that has some most barriers, but we need to know more in depth what's the specific barrier of each country. So I'm going to show you just an example of what it could be for the information system part. You see, for example, across the 3 countries, there was issues regarding having an inadequate population registry. It wasn't the same issue specifically in all of them. You see, for example, both in the South American country and the Central American, they didn't have contact information of the eligible population, but this wasn't one of the barriers mentioned by the Caribbean country. But they mentioned, for example, that the population register wasn't timely updated with changes of contact, and this was also a barrier for the South American country. There can be issues of not having an adequate information system, like there was mentioned in this Central American country, not an adequate collection and tracking of information. Like you see, for example, as I was mentioning before, this was one of the barriers they highlighted, the inadequate system for monitoring participation, but it can be also that they don't collect follow-up data of that population that participate in screening. And then another issue could be, like as I was saying also at the end, the difficulties of sharing and linking information, be able to link different information systems to actually track the woman or the man, if it's colon cancer also, along all the screening pathway. So this is something that we've been working on, and like we've been working on a tool. I'm going to like show you like just an image of how this would look like. It's still the content is developed, but not yet all the graphical parts. So this is like something only like the beta version, let's say, that we showed with we discussed with the graphical designer. So you see, this would be, for example, an example of one country with the various dimensions they selected and some dimensions within the subcategories within the dimensions of what the barriers would be. And the idea is with the tool we've been working on, you will be able to see, for example, the country would fill in, or the screening provider would fill in, the screening program manager would fill in the questionnaire. He would come up, or she would come up with this framework, and then you would see specifically each of the barriers they selected and see what's the evidence behind possible interventions that can be used to overcome that barrier. So you see this, in some cases we have systematic reviews supporting the effectiveness of certain interventions. You see, for example, here a mobile unit for breast, for the 3, breast, cervical and colorectal cancer. We have also patient navigation. We have also interventions that are part of a multi-component strategy, so we don't know on their own how effective they would be, but we know they are effective within a multi-component package. Let's say, for example, provision of transportation. This, I mean, we can't think it's going to be useful on its own, but there isn't studies supporting this at this point. There can be also interventions that there's limited evidence on this. There isn't yet a systematic review, but there's some evidence pointing to the fact that it would be useful, this intervention. For example, offering a choice of screening method for colorectal cancer has been studied. And then there's also some macro level approaches that these can be like recommendations, actions, policies that set up this macro level context that facilitates overcoming the barrier. So we can have, for example, engaging with civil society or reorganizing the facilities to actually provide the service or plan new facilities, for example. And then within each of these interventions, we have like explanation of what this intervention means, what's the definition, what we need to consider. For example, if you're talking of mobile units, we need to think if the areas where it's going to, how frequently, that we need to inform the population in advance that they are going there, so they are well aware that they can access that service that day. Then we've listed several countries where this has been studied, and an example of a reference that could be used to get further information. And so to conclude, well, you can see that we've been working on this tool also because we want to give tools to the countries to conduct a systematic assessment of barriers, and also making them think of how to prioritize. And this will actually facilitate them to identify what could be evidence-based interventions to overcome those barriers, and it will help the countries to make better informed decisions in this sense to improve this, to overcome these barriers in the cancer screening pathway. Thank you, and now I'm open for your questions. To stop sharing.
Thank you very much, Isabel, for the very nice presentation. And so I think we can go for the questions right now. So I will start with a question that I've seen in the chat. And so this is the question from Atanase Munianeza, I think from Rwanda, if I'm not wrong. So, do women with cervical cancer who have a high level of education in sub-Saharan Africa have survival rates comparable to those in high-income countries? If so, we can conclude that education level could be a predictive factor for cervical cancer. So, first of all, somehow I think I can reply to this in the sense that education level is a predictive factor for cervical cancer incidence and mortality and survival basically everywhere. With respect to the comparability across countries and continents, this is more difficult, and this is why in my presentation I was insisting on the fact that it's important to have comparable data across countries, because, for instance, high level of education in one country might mean something and in another country might mean something else. But so it is difficult to say whether a woman with a high level education in one country in Africa is comparable in terms of socioeconomic status with another woman in Europe, because the context changes, the education, what being educated means, literacy, the possibility to have access to healthcare is different, the healthcare system. So there are many reasons why it's difficult to compare this data. But we have seen within Europe, in the more developed part, I mean, we have done this comparison between across Europe on the more developed versus less developed countries, and indeed, as I shown before, women with high level of education, there seems to be in a relatively similar situation and more favorable situation, no matter where they live. So this would be my reply. Then we have another question that is probably for Isabel. So what are the specialties of the cancer prevention of the Roma, or I think the specificities? I don't understand. What are the specificities of the cancer prevention of the Roma origin people and the poor citizens? This is a person from Hungary.
Specificities of cancer prevention.
Yes. So I guess it refers to what are to your example that you will do about the Roma people. What are the specificity to carry out prevention programs?
So the thing is, in many cases, the Roma population are not accessing the, let's say, the non-Roma screening services. So in several areas, I don't know about Hungary because there are not expressions coming from Hungary. I don't know how it is there, but for example, in Romania, they have like community networks where there's a health mediator actually contacting the Roma population and doing the different recommendations for cancer prevention. I do know, I mean, the information we have so far is that the participation in screening is normally lower among the cancer screening, sorry, I didn't specify. And the cancer screening is normally lower. But we also have information, for example, on the incidence of HPV, and also it's normally lower among the Roma population. That's the only information I have, because for other cancer sites, I don't have information of how they are participating for breast cancer screening or colorectal cancer screening. Sorry about this.
And okay, so I think there is another question with from Atanase from Rwanda again, from the accessibility variable. What was the optimal distance that serves as a standard for getting to the healthcare facility? By what means of transport? I think this would still be for you probably, or? I
think it's more yours, because for the ABCDO, I think you participated in that one. In the study I conducted, we weren't actually measuring the distance or asking them to qualify the distance they had to take to to get to the different screening services. It was only if it was a barrier for them. But I know in the ABCDO study they did measure this, I think. I think you were involved in that, right, Salvo?
I don't know. I think there is no really ideal distance. I mean, we know that the farther away the person is, the more difficult it is to reach the center. So, but this needs to be considered at least. So, with implementing other interventions that could reach also these women. So, and then there is Azarelli Fernando, another question. In Sri Lanka, we have done most of the intervention mentioned to increase participation for cervical cancer screening. Still, it is stagnating around 50% for the 35-year group and very low for the 45-year group. It's not clear how much is it for the 45 years group, but I wonder what could be done to increase this uptake, provided a similar study being done in Sri Lanka as well.
Well,
so how to increase basically the relatively low and stagnating uptake of cervical cancer screening? Isabel, if you have any, in Sri Lanka, this would be.
Yeah, so, well, I don't know the context of Sri Lanka, so I can't really provide insight in that sense. But we need to know, I mean, I don't know if the services are, as I was saying, available, accessible, all those steps. But also, we have to think also if apart from that, if the people accept it, is there any like issue that making them not attend screening? Can it be that they are not accepting because of their beliefs? Or can it be that they don't trust the healthcare system? I think this needs, obviously, like a study, I can't really tell you because I haven't done anything similar in the context of Sri Lanka, but I think the questionnaire could guide you in this sense to actually identify what could be the issue and what could be the possible interventions. But because also in the questionnaire, we ask about different interventions they had in place. And in some cases, we can see that they have a barrier and theoretically they have an intervention that could be overcoming that barrier. So we need to look at how they are actually doing this. That's why I was showing you before in that tool, we have included a section of elements to consider, because you may not be doing it, let's say, the right way to actually overcome that barrier. So we need to look in depth into that. I would suggest to do something similar. If you want, you can contact me and we can see what could be done to look more in depth what's the main issue in Sri Lanka.
Thank you very much, Isabel. So the next question is probably is for me, and what is the link between social inequalities and cancer prevalence? So usually, prevalence is affected by incidence and by survival. So usually we study the link of social inequalities with incidence or with mortality, and usually. With mortality, we know that basically for all cancer types, there are socioeconomic inequalities in mortality, in cancer mortality for almost all cancer types with a different intensity of the association. And whereas for incidence, when we consider incidence, this pattern is similar for cancer that are affected by risk factors for which there is a strong social gradient in risk factors, for instance, smoking and so on, like smoking-related cancer or cervix as well. But for other cancers, the relationship between socioeconomic position and incidence is a bit different than compared to mortality. So I do not know, and it really depends on the cancer type and on so with survival of this cancer, and so on, and the specificity of the cancer. So. Another question, in developing countries, how do you solve social inequalities in cancer? This is a registrant from Nigeria. This is a very challenging question, and it is very difficult to solve all the social inequalities in cancer, but certainly it is important to start acknowledging that they exist and that they are one of the socioeconomic condition is one of the most important factors explaining the patterns of cancer. And the first step would be to measure them so that policymaker and scientists, they realize that this is an important issue, but also how important is this issue and how important is to invest in reducing social inequalities in cancer. So it is a very difficult topic, and not only in developing countries, in all the countries in the world. So there is another question for Isabel, I think. No, okay. So there is another question: how other countries could construct similar population data sets for the research regarding social inequalities on cancer outcome done in the EU, necessary and feasible? So this is a very good question. The answer is that the data set that we've seen in Europe is quite unique, and it was built by some people at the Erasmus University quite some time ago. The idea was to link cancer mortality data with the information derived from census, information on education level derived from census. So this is a very complex process because it involves different countries and the possibility to access data in different countries, and it's not always possible or easy because there are of data protection issues, but also for issues that every country is not, more and more countries do not want to share their own data. They want to analyze their own data, and then they do not, they're not really keen to do that. So how feasible is how to do this outside the EU? In some other high-income countries like New Zealand and so, they are already doing that. But in more low middle-income countries, it might be more challenging, and I'm not aware of any type of study done in these countries, but I believe it would be very important to do that. So could you share how importance of information of cervical cancer screening registry components in cervical cancer screening program? So what are how it develops since the beginning of the program? Isabel, probably this is for you. I'm not sure I understand it clearly, but probably what are the most important components in cervical cancer screening programs?
I guess what that question comes in the line that there can be, you can collect a lot of information to actually follow the woman or the man on the screening pathway. And I guess the question is like, what would be the minimum? So like we would need to be able to identify the person uniquely along all the pathway. So we need to identify if the person participates, the screening test results, then if they go to further management. So there's some like minimum data, but also if we have information on the delays in all this step, that would add information also how your information system is working how it's working. So you need to like think of like small parts, like the key steps, and then like ensure that, and then be able to actually add the other components that qualify more your screening program, I would say. I don't know if that's answering the question. If not, just write in the chat or raise the hand. I don't know who asked this.
Okay, thank you, Isabel. Another question on opportunistic and organized screening is from Swan Lu. For the inequality issue in cancer screening, there are opportunistic screening and organized screening. Is this necessary to assess the socioeconomic inequalities for each type of screening? I can provide an answer that maybe Isabel can correct. In my opinion, inequalities occur predominantly when there is opportunistic screening, because it is women that have a higher possibility to access screening programs, opportunistic screening programs that will benefit from that. So in order to reduce socioeconomic inequalities in cancer, it would be important to have organized screening that can reach all segments of the population. So I do not know, Isabel, do you want to add something? So opportunistic screening is not something that you would like to have in general, but you would like to have a well and efficient organized screening that reaches everyone in the community.
Yeah,
Isabel, do you want to add something?
Yeah, the thing is of opportunistic screening, organized screening, sometimes it has been used like one's the opposite of the other. And really we have to think that organized screening, we are looking at having many elements in place that make things work, let's say. So this can happen in opportunistic screening. But it's true that this doesn't guarantee that all population is going to be invited. So the thing is, we have to try to think of a screening actually approaching all eligible population, so what we call population-based, but this doesn't guarantee either that there's no inequality. We have to actually make sure that everything's in place to actually be able to provide adequate service, quality assured service. So to be more specific, is it necessary to assess the sustainable inequality for each type of screening? Well, you can assess, but you would aim to have an organized screening, have as more organized as possible, inviting all eligible population. This, if you have a population register that allows you to identify eligible population, you are reducing this socioeconomic inequality. If people are actually aware of the relevance of screening, because also this invitation gives the population idea that this is important and can help in this sense, for their acceptance to go to screening.
Okay, thank you very much, Isabel. There is one question for me. If you have time to choose which intervention towards reducing social inequalities in cancer, I guess, would have the highest impact on reducing cancer mortality? So from the, this is a very interesting question. From the number point of view, from the absolute number point of view, probably still anti-smoking campaign would be very important, because lung cancer is still a big killer, and so reaching also low income and low education individuals all over the world in order to make them stop to uptake smoking or to stop smoking, that would be probably the most effective intervention. But also cervical cancer screening would be another important intervention, so to reduce social inequalities in cancer. So I mentioned two of them, and it's important to notice that most of the inequalities could be avoidable, because, for instance, we know how to, the most important risk factor for lung cancer, for instance, which is one of the major killers. We know how to prevent cervical cancer. So there are ways to reduce it. So, and for these two cancers, it is possible to reduce inequalities and reduce the burden of cancer. The problem is how to reach all the segments of the population. And so this is the challenge. So another question: in India, we have another question, I guess, the time for another question, and then the time is running out. In India, we experience susceptibility to screening increases if provided at doorstep level, including one-to-one education and self-sampling, and has shown more acceptability than speculum examination for cervical cancer at last visit. Capacity building and repeated retraining of CHW really helps. You want to comment on this, Isabel? Or
yeah.
It's just a comment, probably.
Yeah, well, just in line as Subhadra was saying, yes, here we are you are combining several interventions. You're having these community health workers going door to door, so that's increasing accessibility. Also, you are increasing awareness because you're providing this education. And also it's true that the self-sampling in many contexts is more acceptable than having to go to the provider to have the sample taken. So you've combined several, and this has been shown in many places that it's useful to actually overcome these barriers. So yeah, a good example of how what I was showing works.
Okay, there is maybe time for another comment, another question. Are there any studies showcasing inequalities when look at health literacy and education separately? And also, how can health literacy be improved at policy level? Again, yes, there are studies showing that health literacy is very important to reduce inequalities, and also this is another issue that health literacy should be brought up at the higher level to raise awareness about increasing health literacy. Very last question, I guess. Thanks with this very interesting presentation. Even in high-income countries, data on health inequalities in cancer prevention are scarce. How do you advocate for better addressing this issue? Do you do statistics about socioeconomic factors in various countries, and then those in urgent need can be assessed at first? Yes, there are little data and awareness is scarce. So how do we advocate for that? This is a good question. We try to show more and more this data because we think that the data speak somehow for themselves, and they show that this is an important issue. And we hope we want to bring the best quality data to policymakers and politicians and people that decide, so that they will also take the necessary intervention to reduce socioeconomic inequalities in cancer. There are a few other questions, but I'm afraid we will not be able to answer them all. And I would like to thank you all for attention. And thank you very much. Sandrina, do not know if you want to say the last word or...
Yes, sure. Thank you very much.
Okay.
Salvatore, Isabel, it was a great session. Thanks for our viewers on YouTube and all the interesting questions. You can see here the next event will be on Friday, the second of the series, and still in the implementing cancer prevention and early detection module. So check out our program on our web pages, and we see you soon. Thank you. Participants will stay in the session. We will observe a 10-minute break and come back to have a practical sessions with our faculty today, Salvatore, Isabel, and also your facilitators. Thanks. See you in 10 minutes.